Hello, my name is Mike Dempsey. I am a respiratory therapist here at Sutter. I'm going to show you the VDR4, or volumetric diffusive respirator. It is a high frequency device that looks very intimidating if you look at it like this, but once we kind of show you how it works, it'll become much more clear. It combines kind of the best of both worlds of conventional ventilation and high frequency. It provides really small tidal volume pulses in addition to regular conventional breathing. The VDR is a pneumatically powered, flow-driven ventilator. That means you don't need electricity to run this, but you do need gas. Some of the advantages of this ventilator: you have a really sick patient, low lung compliance. This can open their lungs, ventilate them in a safer way than creating barotrauma. It will also remove a great deal of CO2, provide oxygenation, and is very effective at secretion removal. It's one of the main reasons why we use it. So let's first talk about the circuit. This looks a little bit intimidating, but basically what we need to know is that this is what is controlling all of our ventilation here. This is called the phasotron. This piece, the main flow is going to come to power the ventilator, is coming through this tube. It's going to move this phasotron back and forth, which is going to create all the pulsing, which is going to make the patient's chest vibrate. The rest of this is basically for heat, humidification, and a little bit of extra flow if the patient needs it. One of the things about this machine, it's all flow and pneumatic, so there's a lot of flow that goes through here. The patients can get very dry, so that's why we have two heaters with all of our setups here to provide a really high amount of humidity to make sure the tubes don't plug off. Okay, we're going to turn on the machine. First thing we do, we have it connected to gas source over here. We are going to turn on our working pressure, and that's going to be dependent on the patient size. If it's a neonate, it's going to be about 30. If it's a pediatric, 35, an adult, 40. Sometimes, depending on the vent settings, you're going to need more or less of that. Here is the on-off, the master switch. So to turn the ventilator on, boom, we're on. To get our monitoring levels, we have a switch in the back of the machine that will turn on those two. Oops. Ready? So with this ventilator, the only electricity you will need is to have your monitoring readouts available. If your power goes down, it's still going to ventilate the patient. You just won't have your printouts, your readouts here. We can still monitor the pressures on your gauge. So that's one of the things about this machine. You don't need a battery. And as you can see, this is how the phasotron moves. This is pulsating whatever we have set, and currently it's at 475 times a minute. Just a little bit about these tubes here. As you can see on the plate, we have your red monitoring line, which is basically your gauge, and that is how you're going to actually, this is what's sensing our settings and giving us our pressures on our gauge. And this is the phasotron, which is the most important line. This is where all the ventilation is coming from. All the flow is coming through this tube here. You can see it says phasotron there. These other two are just providing some extra flow to power our heaters and our humidification system that goes to the patient. Let's look at the top of the machine. here we have where our working pressure is set. You see our gauge here is at about 40, so that's going to be dependent on the size of your patient. Here we have our pressure readout gauge. You can see the top number is 27, that's your average inspiratory pressure. Bottom number is 10, that's your average expiratory pressure. The middle number is your mean airway pressure. And then over on the right here is your the rate, the high frequency rate. When the doctor orders settings for this ventilator, this is where they're going to be set. So if they want to have 30/10 and a rate of 500, you're going to set the ventilator so that's where it's going to read 30/10 and a rate of 500. Over here is your oxygen analyzer, or your blender. This is where you're going to set your FiO2. And in addition to this, we have our oxygen analyzer here, just to make sure that it's easy to see what kind of FiO2 you're on. Let's go over the front of the machine. This is the intimidating part. You have all these different names for simple kind of respiratory parameters. Pulsatile flow rate is similar to your PIP. Oscillatory CPAP, or PEEP, is similar to the PEEP. Inspiratory and expiratory time are going to be used to set your convective rate. For most patients, we're going to use a 1-to-1 IE ratio on these, and they're going to be here. We have demand CPAP, which basically adds extra flow to the patient. Like, say you have somebody who's over-breathing the ventilator, it seems like they need a little bit more flow, you can add some demand CPAP. Basically what that'll do is that's basically like real PEEP, it'll just add PEEP to the system. This is the convective pressure rise. Very seldom do we use this. It is reserved for usually the sickest patients with the most whited out lungs. What it will do is will add pressure during the convective breath. It'll accelerate the flow and help pop those lung units open. Again, we don't use that very often. Here we have our pulse frequency, which is our high frequency rate. And then our pulse IE ratio, which is basically the IE ratio of our high frequency breaths. Usually we'll leave that at 1-to-1. You can do some manipulations on that, depending on what's going on with the patient, but in general, we leave that where it is. Here is our fail-safe alarm. This will alarm if something happens to your phasotron, it becomes blocked in some way, or this tubing becomes kinked, it will alarm and just shut the vent down. Reset it right here. This nebulizer switch is basically just adding flow into our humidification system. So you want to make sure that this is on. If you start the vent with it off and then you decide to add it on, it's going to change all of your vent settings because it's going to add more flow to the circuit. And then you have your manual breath button. I don't advise using that. There's no set eye time on it. You hold that down and it will just release gas to the patient. It'd be better just to bag them with manually with a bagging mask. Next is our monitoring screen. We have it in two places. Here, this very small screen here, and we've attached a nice big screen so you can see it from far away. Basically what this is doing is all of these numbers are coming through this red line. I'm going to make sure this red line stays clear of any kind of humidity or any kind of fluid. So we have our filters in line through there to prevent that getting back in the machine. Here is our waveform. And as you can see, this kind of really illustrates the benefit of this machine. You have your high frequency ventilation pulses in combination with your really large volume conventional ventilator type breaths. Here we have it set at a rate of 15, so 15 times a minute you're going to see these big breaths. This is the big volume where the chest is going to rise. And then 500 times a minute, you're having these small vibrations. So even during the expiratory phase of the patient down here, you're still going to see their chest vibrating. All of that is for secretion removal, CO2 removal, and oxygenation. For our convective rate, we're going to set it here. And we're going to, for the most part, use a 1-to-1 IE ratio. So 2 and 2, it's a rate of 15. There's some other, here's your mean airway pressure, peak pressures, your CPAP. This is a really important thing. It can tell you a lot about what's going on with the patient. Is your circuit set up correctly? Do they need to be suctioned? Is there a big air leak? The waveforms can tell you a lot about that. One of the main considerations for this ventilator, there's so much flow going through here, so much gas, patients can become dry. So one of the really important things is making sure that your circuit is humidified, patients suction frequently, and one of the ways you can tell that is by the chest moving. This machine, we can set the pressures on it, but it's not telling us what tidal lines are. So the way we're going to be able to really see what's going on is to actually watch the patient's chest moving. You see a decreased chest movement, suction the patient. If you're getting a lot of secretions, one of the ways you can also, this machine will help get rid of even more secretions, is to deflate the ET tube cuff a little bit, and it'll actually pull secretions right out through there. That will also get rid of CO2, so that's one of the things you can do if you're having high pressures, you're having high CO2s, you're already on high pressures on your ventilator, you can actually deflate the cuff a little bit, let some of that CO2 escape. One of the things that's really important, this is very cumbersome for a small baby on it with a little ET tube. So when you're going to reposition the patient, you must have the RT there. It's got to be at least 2 people, and just be very careful. This does swivel, which is kind of nice. So you can kind of just turn it in all different configurations. But again, you need 2 people to do this because this is a lot to kind of move around. Just want to show you what the alarm sounds like if the working pressure line gets plugged and shuts down the phasotron. That's what it sounds like. And then you just reset here. And that's usually because it's kinked. Or there's something going on with the phasotron, there's something that's built up in here and it's blocked. In that case, you would have to just change the phasotron out. The most common way that this can get included is getting kinked, usually in the bed rails, or sometimes it can get pinched if somebody's leaning on it. So just be aware of that. Just keep this in a clear space at all times. The other really important thing is this is where the patient is exhaling. So if this becomes blocked, they're not going to be able to exhale very easily. So make sure that this stays into open air. And you can see it's nice because this actually moves around. So as you're repositioning the patient, you can actually move these so they're not blocked and it cause the patient not to be able to exhale as easily.
So Mike, what do I do if my patient's desetting?
If your patient is desetting on this ventilator, the only move you can really make is the FiO2, which is right here. And then call your RT right away. If you have to make a large adjustment in FiO2, it will affect the settings on the ventilator because it's all based on flow and it's all being driven by the pneumatic pressures. So changing the FiO2, greater than 10%, it could change the settings on the ventilator itself.
Okay. So you're saying I'm only allowed to touch the FiO2 button?
That's correct.
Okay. What do I do if my patient becomes disconnected from this?
If it's disconnected, you can try to identify where it's disconnected, reconnect it. It'll still, and then you're not going to lose anything on the settings. If you get it reconnected where it was disconnected, it'll come right back to where it was. If you can't do that for whatever reason because there's so many tubes here, you call the RT right away. If you notice the chest is not moving, you just bag the patient until the RT gets there.
Okay.
So that covers the VDR. If you have any questions or concerns, you can contact the pulmonary clinical specialists, NICU or PICU. Thanks very much.